Hi, this is Dr. T from EVMS with another episode of UltraSoundbytes, and today I'm going to talk about the parasternal long axis or PLAX view of the heart. So we're going to talk about the clinical application of the heart, the machine setup, patient setup, the acquisition of images, pitfalls and pearls, and there are going to be scanning instruction cards on Blackboard that you'll have access to. So the clinical application and use for the PLAX view of the heart, first of all, it provides you a potential window to look at the heart. And remember, we have really three basic windows: parasternal, apical, and then subcostal. And typically people either have very good high windows or good low windows. They don't always have all good windows, so this becomes one of the windows in your toolbox. This is a very good window for ruling out cardiac effusion and tamponade, for estimating visually the cardiac output and ejection fraction, and as a means of ruling out hypo or hypervolemia. So you are going to set your machine up either the way Blackboard instructs you to if it's a lab, or the way your preceptor instructs you to if you're using this clinically. Your preset, your exam preset, should be cardiac or adult cardiac, but remember that you can perform a PLAX image in any of your fast exam settings, but that your probe indicator will be reversed. You're going to use a phased array transducer, and you're going to keep all of your other machine settings at neutral until you begin scanning. When we talk about the PLAX image, your marker is going to go to the patient's right shoulder if you are using a cardiac preset. And the idea between that behind that location is to stretch out the long axis of the heart from base to apex and give us a view that lets us see a little bit of several chambers at once. If you use any of the fast presets, the notch will then go towards the patient's left hip. You're going to want to keep the probe as close to the sternum as possible, and you're going to be scanning somewhere between the second and the fifth intercostal space. Typically, I will start very high and then move inferiorly if it's not an adequate window. You're going to be using heel-toe, sweeps, and pivots as your motions. And your patient position, supine, LPO, often the best position is LLD, and you want your patient to put their arm up over their head because it'll help stretch out your intercostal spaces and make your scanning window a little bit easier. Remember, when we're talking about imaging the heart, it's hidden behind lungs and bone, and those are all components that are not ultrasound friendly, and so patient positioning is really going to be key. These are very small acoustic windows, so any change you can make as you position your patient will be helpful. And then remember your anatomy. The right ventricle is most anterior, and it'll be near the top of your screen, and the left atrium and the descending aorta sit the deepest in the body, and those will provide very good benchmarks for you deciding if your depth is appropriate. Once you begin scanning, then you are going, first of all, to select the appropriate intercostal space. And if you start at the second, that is often a little bit too high, but slide inferiorly until you find the appropriate intercostal space. And then once you have an image of cardiac anatomy, begin making other adjustments, including to your depth. Make sure you include the descending aorta and about 1 finger of space deep to the pericardium. You would set your focal zone if it's adjustable on your system. If so, your focal zone always is set to the deepest border of the anatomy of interest. And then you're going to set your gains and your TGC. Lastly, I want to remind you that you may have to pivot the probe based on the body habitus of your patient. So if your patient is long, with a very often long, thin torso, these hearts tend to lay a little bit more vertical in the body, and you're going to have to rotate the probe slightly clockwise to get a more close to a sagittal window. And if a patient has a kind of a short, stocky build, then you have to go more transverse in the body, rotating your probe more counterclockwise. Now, again, if you're imaging this in clinical, then you're not going to be documenting anatomy on the image, but you are still going to try to remember that nothing that you scan should be anonymous and not on top of your anatomy, but somewhere in the black background of your machine, empty screen. You need to put your last name, first initial, your ID, the big anatomy you're scanning. In this case, it's plaques of the heart. And then I've added here diastole because as a lab, one of the things asked for is what cardiac cycle are we in. So make sure you have that anatomy labeled. And then often for a lab, there's going to be some other anatomical items that are addressed, and these you can place either on top of the image or just off to the side of the anatomy and use an arrow. And so for today's lab, excuse me about that, for today's lab, the items that you are being asked about are the 4 cardiac chambers, 3 of the cardiac chambers that we see: the right ventricle, the left ventricle, and the left atrium, the 2 left-sided valves, the mitral valve and the aortic valve. Again, we had to decide our cardiac cycle. We have an open mitral and a closed aorta, so it is diastole. And then you have to identify one artifact. I chose a quite unusual artifact that I just happened to catch on this image. You can see here there are 2 anechoic and round structures sitting side by side. This means that this is a refraction artifact. Refraction artifacts sit next to each other, side by side like this, and occur because of a change in scanning speed. If it was a reflection artifact, then the artifactual echo that's demonstrated would be placed deep to the real echo. So reflections lie deep to their originating structure, and refractions lie adjacent, side by side. And at this time, I'd like to go to the machine, please. So before I show you my own screen, I'm going to put my probe automatically towards the right shoulder of my patient, and I'm going to start quite high. And I'm going to slide inferiorly. No good window. So this is actually really appropriate. Now what I'm going to do is I'm going to have my patient roll away from me, please. And I'm going to see how that changes. Just lean right against me. And there you go. Perfect. And so I'm going to start high. And I'm going to come inferiorly until I get to my window. So I start high, move low, and here is a great example of a supine window just with too much lung interference. So now I am going to go to my machine proper. I'm not really paying any attention to my exam. I want to make sure that I'm on adult cardiac for my preset. Oh, I'm working on it. No, I'm on it. And so now I'm going to adjust my gain to brighten the image up. I notice I have some wasted space on this image, so I'm going to decrease my depth by only 1. I'm going to adjust my scanning plane a little bit. And now I'm just going to let my patient breathe, and I'm going to let just breathe in and out regularly. I'm going to let lung interference kind of come and go with her breathing. That's perfect. So just as a note, if you angle towards the right shoulder, you get more base of the heart. And if you angle towards the left hip, typically you get more apex, more left ventricle. So I'm going to let several cycles go by because this is a dynamic exam. And as soon as this comes back in, I'm going to tweak my image back. You just hold your breath for a minute. Stop breathing just for a moment. And I'm going to freeze what will be the representative image for this lab. Thank you. Now that I have selected the image I'm going to use, I am going to label this up. So the first thing that I'm going to do is I'm going to put my last name, first initial, ID, what I'm scanning, Plaques. I have to add something here. My patient was in a different position, so I'm going to write the patient position in here. She was decubed. And then remember we said in this lab we have to identify cardiac cycle. So I still see my mitral valve open, and I am going to call this diastole. Now I'm further going to go ahead and add in the items for the lab. Right ventricle, left ventricle, the mitral valve leaflets, the left atrium, and the aortic valve. Not seen quite as well as the mitral. And now I am going to save this. It is automatically going to prompt me to write my information in the machine. Alright, I'm going to hit OK. So now I have my corresponding select image that I'm going to submit, and I'm going to hit the button up here that saves Cine. So now I have a Cine clip if I wanted to go back and select a different frame, plus I have my representative image that I'm going to submit, that I'm going to take a picture of and submit to faculty for evaluation. The other item that you must not forget to label is one artifact. Now, I don't see a nice refraction artifact, but what I do see is some posterior enhancement. So I'm going to go for the tried and true PAE here. And I'm going to label that PAE. And so now all the requirements for the lab are labeled, and we are going to go back to our computer and finish this section of notes. So I'd like to give you a clinical pearl. First of all, this can be a wonderful view of the heart for you to look at valvular function and estimate the ejection fraction. And what you would like to see is a normal heart like we just looked at, that you see here, where the anterior mitral valve leaflet comes up close enough that sometimes it might even touch the septum. You want that anterior leaflet to have very good separation and to approach the septum. And that would represent a good normal range of ejection fraction, which is somewhere between about 50 and 60% for most normal folks. But here on the right-hand side of the screen, you can see that the mitral valve and in turn the aortic valve both have a very limited opening diameter. They really have very minimal displacement as they open, and if you think about it, if blood can't get out the left ventricle, then it can't escape the left atrium, and we often begin to see chamber enlargements here first, even before the right heart becomes involved. And so you don't know why these valves are not opening fully. All you know from this view is they are indeed not opening very well. Not the reason, not the cause, just the impact. Now the artifacts that we'll encounter in this view are fairly standard. So I should probably add that refraction artifact I showed you. That is very unusual. I actually myself had to think about it for a few minutes before I chose that artifact. So I don't expect that that would be the one that you pick. I would like to talk about an SPI snapshot, and what I'd like to discuss is field of view. So on your machine, on any machine you scan on, you can change your field of view or your sector size or sector width. And what you need to remember is that everything your machine does is limited by this formula. The frame rate times the lines per frame times the depth times the number of focal zones cannot be multiplied together and equal more than 77,000. They should, when multiplied together, equal less than 77,000. And it's just a limitation on what your computer can keep up with based on the speed of sound in our body. And so when you look at this formula, you can see that one of the things that we're going to encounter right away is our frame rate, and that's often where we have problems. So if I scan with a standard wide sector, and this is how most systems default, you can see that the frame rate now is 41 frames per second. But if I narrow my sector size, two things happen. First of all, my frame rate's higher. It's up to 65 frames per second. So now I'd be able to add in other functions, perhaps like color Doppler, without reducing my frame rate enough for me to see image lag or flicker. But there's something else that happens that's very important, and that is that your machine is built with a set number of lines to develop your image. And when you narrow the sector size, you have the same number of lines, but they are squished together. When they are squished together, this means that our side-by-side resolution or our lateral resolution is greatly improved. So using a narrow sector width can help improve your lateral resolution, which is always not very good, and can improve your frame rate, which is always the first thing to suffer when we start to use multiple tasks on our machine at the same time. The clinical pearl I'd like to leave you with next is this becomes also a very good window for you to assess both cardiac and pleural effusions. And you'll notice that the pericardial effusion is located between the posterior left wall and the pericardium. And then a pleural effusion would be deep to that. So you can see how important it will be to leave a little bit of depth deep to the heart. Otherwise, you would automatically miss a pleural effusion, and you might even miss this pericardial effusion. Now, the shape of these pericardial effusions, which tapers to a point as it reaches the base, is often referred to as a rat's tail appearance. So if you hear that, that's what they're talking about. And remember that some of these effusions can be quite sizable, and you might have to really add a lot of depth. Look at the depth on this image, over 20 centimeters now. So you might really have to increase your depth just to show a pathologic finding. But you want to make sure that you set your starting depth so that you wouldn't miss that effusion if present. That is it for an ultrasound bite from EVMS. We thank you and hope you stay tuned for our next offering. Bye.